So welcome everybody. I'm Sarah Humphrey. I'm the clinical lead for Old People's Mental Health and Dementia for the Clinical Network. I am a GP with a specialist interest by background, though I stopped being clinical earlier this year. So we're here to introduce our new toolkit, Appropriate Prescribing of Antipsychotic Medication in Dementia. As Colin said, there will be a QR code on each slide set. If you want to just have a look as we go along, that's absolutely fine. This is really informal. The plan is I'm going to just do 15 to 20 minutes just introducing the toolkit, and then I hope that we're just going to have a bit of a conversation about how you feel about anything that I've mentioned or about antipsychotics, and just get a feel of how you might use the toolkit, what you thought about hearing about it, and just a bit of a conversation. As Colin said, please do introduce yourselves in the chat box. Think of questions if you're a little bit don't have a mic or are thinking a bit shy of speaking in person. Please do put your questions in the chat room. I did hope that I would be joined by one of our consultant colleagues today, but you know what? There's plenty of people on the call who can answer questions that I can't. I'm really here just to talk about the toolkit and just to get you thinking, really. So let's start. So what we're going to quickly look at is why we did a toolkit, and then look at the various sections of the toolkit and what they give you. We are going to do a review of the toolkit and add in new material in 12 months, because as soon as you start publicising it, people send you some great resources. So in 12 months' time, we'll be doing a new iteration, and we hope that this is going to be a continually live document, and we hope it will be hosted on the London network site, so it's free to everybody, but also on NHS Futures. And we hope that on NHS Futures that you will have a debate about the things that you find useful. Send us stuff that you want in the next iteration, and we will give you a address for the England team to send you materials in should you find that there's a gap to fill. So I thought I'd start off with distress behaviours. And that's what I like to call them, distress behaviours, because when the brain has a function, and obviously if we have difficulty processing information, we have sensory deficits, we have changes in routine activity or physical reasons such as pain, being unwell, hungry or tired, that might be communicated with people living with dementia as and can lead to anxiety, anger, frustration, and then that leads to an outburst of distress behaviours. And I think if we reframe how we think of challenging behaviours into distress behaviours, that might help us think about why they're happening and make us think that actually not everything can be solved by giving an antipsychotic medication. So that's just something to hold in your thoughts there. When can antipsychotic drugs help? And you've noticed that we've called the toolkit an appropriate prescribing. So we're not saying never. We're not saying they're dreadful in every use, but we're saying, when is it appropriate to use them? So when can they help? So drug trials have shown that risperidone has a small but significant beneficial effect on aggression and to a lesser extent psychosis for people with Alzheimer's disease. And these effects are seen when the drug is taken for a relatively short period of 6 to 12 weeks. That's it. That's what the evidence shows. Antipsychotics do not help with other behavioural and psychological symptoms such as distress and anxiety during personal care, restlessness, agitation, repetitive vocalisation, shouting, walking about, as some people would call wandering, walking with purpose, social withdrawal, and in changes in levels of inhibition, for example, saying or doing things that are inappropriate. There is no evidence from any of the trials that these symptoms are supported or made any different by antipsychotics, and they need a personalised non-drug approach. If we are going to use an antipsychotic, which antipsychotic should we use and what are being used for people living with dementia? So a lot of you will have seen that risperidone is previously been the only one holding an official licence for short-term use of aggression in Alzheimer's disease if the aggression poses a risk or the person has not responded to non-drug approaches. Quite recently, haloperidol has gained a licence, but only in persistent aggression and psychotic symptoms in moderate to severe Alzheimer's dementia and vascular dementia, where non-pharmacological treatments are ineffective and there is a risk of harm to self or others. So that's the only two that have actually got a licence. The rest of the antipsychotics that are used are done so off-label, which means a doctor or prescribing clinician, as we move to different prescribers, can be prescribed if they have a good reason to do so and provided they follow the rules set out by the General Medical Council. People sometimes think that by putting this slide in that I'm advocating their use. I'm not. A person with dementia should only have an antipsychotic if they are at risk of harming themselves or others or are severely distressed. And then it should be tried alongside other activities to help reduce that distress. And that's what it says in the NICE guidance. And the reason that antipsychotics really should be a last resort is actually that they have quite significant risks on that balance scale. Risks of death, stroke, sedation, infections, falls, blood clots, ankle swelling, worsening of other symptoms of dementia, and Parkinsonism symptoms, that's shaking and unsteadiness. So those are all on the negative balance of the scales. And probably what we're finding is people have forgotten some of those risks or don't share those risks with others when they prescribe. Reviewing antipsychotics. So the NICE guidance says that we should use the lowest effective dose for the shortest possible time. Review every 6 weeks. And this was written for an inpatient community, so on a dementia assessment unit or inpatient ward. In practice, that's often a much shorter amount of time on an acute ward, but it might go 6 to 12 weeks on a community setting, care home, or in somebody's own home. Treatment should be stopped if the person is not getting clear ongoing benefit. And the reason why we say this, we do see that people say, well, they've not got any better on the treatment. And they state that in their notes, and then they continue the treatment. Well, if it's not working, why are you continuing it? Unless there is severe risk or extreme distress, the recommended default management is to discontinue the antipsychotic. And you should be monitoring then with ongoing assessment of contributing factors and continuation of non-drug treatments based on person's needs, abilities and interests. And the other thing to say is it's never too late to review and stop something. So just because it's been on for 2 years doesn't mean that you can't review and stop it. I think we sometimes have a fear when things have gone on for a long time, but there is no evidence that it's ever too late. I'm going to give you two references here for 2 papers on deprescribing antipsychotics, and the first suggests that antipsychotics should be can be withdrawn without significant detrimental effects on behaviour in around 70% of people. What stops antipsychotic deprescribing is us, I'm afraid, not the drug, not the benefits of deprescribing. We should be having at least 2 attempts to discontinue before moving to a long-term treatment. We should be gradually reducing them using deprescribing tables and tools, and some of those support tools are in the toolkit. So that's the background of the toolkit and the background of what I'm thinking about with antipsychotics. Another big reason that we decided to do the antipsychotic toolkit is there is really quite big variation throughout England in how much we use antipsychotics. So the sort of baseline is 9.24%. And what that means is nearly 10% of all people living with dementia are prescribed an antipsychotic. That's quite staggering, really. It has been higher in the past and it has come down. But you can see there's quite big variation from, as little as just under 8% to up past 11%. You can see there's a big slide in the rates in October 21. That was just because we changed the method of measuring. But you can see there's big variation. And there's big variation within places. Okay, so it's not that we have different populations necessarily in each region, because what we see in ICB areas, there is great variation. So if you take the one where I'm from, Bradford, and I'm in West Yorkshire ICB, we have Leeds down at 5.5% and we have Bradford at 15%. So variation suggests different cultures and a whole lot of other factors that are causing variation in practice. So that means to me, we should be trying to reduce variation. Why a toolkit? The reasons that people are on antipsychotics is actually really complex and will vary hugely from place to place. There is no one reason anywhere that it happens. We have different resources, we have different populations, we have different local attitudes, we have different community assets, we have different staffing models, we have different environments that people are supported. We've all had different training and we all have different systems and processes. This fishbone diagram that you can see shows one place's attempt to understand why antipsychotics were prescribed. And in the toolkit, you'll find support materials to try and find out what it is happening at your place that is either increasing it, or the converse might be true. Why are you so resilient? Why have you got such great low rates? Okay, so you'll find it's really a complex picture. And people always say, oh, it's so and so. No, it's not. It's a whole complex set of things. So if we move on to what the toolkit looks like, section 1 very much talks about some of the background stuff, what they are, about taking a person-centered approach. It looks at risks and it looks at the interplay with delirium, because we find lots of people have got sort of leftover medication from when they had an acute episode of delirium and they're on it forever after that. So there's all sorts of background stuff about uses and risks that I hope you'll find useful. The next section is around all the non-pharmacological alternatives. So it really tries to give you evidence and helping you to build business cases around antipsychotics, around what are the alternatives. The third section is very much around deprescribing, why you need to do it, when you need to do it, how you're going to do it. And this section also brings in a much more holistic approach, and I don't apologise for this. I think there is more in deprescribing for frailty and dementia than just antipsychotics. So we talk about anticholinergic burden and we talk about frailty in the stock tool. So you'll find tools that will help you do that and an approach to deprescribing. And then finally, what we've done is a bit of a directory of all the tools that can help you. We've brought in audit tools that people have built, deprescribing guidance, how you access your data. Because one of the questions people ask me is, well, how do you know Bradford's 15%? Well, I can tell you how to access that data from the toolkit. And so we brought it all there, and what we've done is colour-coded it depending on who it's most suitable for, whether it's aimed at primary care, pharmacy, care homes, people living with dementia and their carer. And so it tries to give you a bit of a framework for all of those. So this toolkit may have resources from other areas that you can pick out and say, actually, this is going to work. But actually, I would suggest you need to know a bit more about what's happening at your place and then pick out the appropriate resources to help you. So you're not going to just look at this and it's going to give you a stepwise total approach for your area on what you need to do next, because you're going to need to look at the resource and pick the bits out. Always when you finally publish something, somebody always comes back and says, well, you've missed this brilliant resource. So we've already been talking about additional resources around managing pain. And so you're going to find that you have access to other materials, and we would love to see them and see, actually, do they add to the toolkit? Could we put them in the next version, which we're going to leave for 12 months to just see how people have found it, used it? Do we need to do anything, other alterations? If you do, we'd like you to send resources to the England's domain team, a single address. On this slide, you've also got your QR code. So that's a quick run through of antipsychotics. So what I'm going to do is stop sharing, hopefully, in a second. That can't come up with it. Let's have a look.
You stopped now, so
I stopped. Right,
yeah.
lovely.
Yeah.
Okay. Okay, so some reason I can't see everybody, but I will find you all again in a moment.
All right.
Okay, so have we got any hands up, Colin?
There's no hands up at the moment, and there's no questions in the chat box either just yet.
Okay. Right.
But
I've lost
if
my
people
video,
do,
but you carry on.
If people do want to ask questions, please do put your hand up, or just make, if you've just got a general comment, or if you've got a more in-depth question and you want to type it into the chat box, please do.
We're all feeling a little bit. Okay, so yeah. I know some people on this call, so that I know you. Sarah's going to pick on you. Okay, so I'm going to ask somebody fairly new, Claire, to Bradford, about what you think about when you heard that our rates were 15%. Now, obviously, I know this is being recorded, but I always think that if you own a problem, that really helps. So, Claire, what do you think about our prescribing rate being 15%?
Well, it looks on that graph. It didn't sound a lot until I looked at the graph, and then it's the highest out of all the areas. So yeah, it does look to me to be an issue that we need to kind of address in Bradford more widely. And I'm thinking about training and developing staff around the non-pharmacological thinking rather than jumping to medication.
Do you think we've sort of forgotten some of Dr. Banerjee's thoughts around the risks? Because it was 2008, which is actually, for a lot of people, that's a really long time ago.
Yes, that's...
and I just think we've forgotten some of that, don't you?
It's 15 years ago, yes. Yeah. And when you put it like up on the slide about stroke and death being, side effects and, the issues with how it can make people fall and things like that, or not help when somebody's more frail, and the reviewing seems to have gone by the wayside as well, on the level that you're asking for on the slides for it to be. But yeah, I can see that. I can see how we've forgotten.
I think we have, and I think that forgetting has meant that we've and Zuma, I was going to come in next to you because you are totally on the top of the tree, aren't you? Leeds at 5.5%. How amazing is that? And have you got insights on why you might be so good?
So I was going to comment plus reminder as well for everybody. So, it's so helpful to see that list, because I'm going to speak for myself. When I start thinking about prescribing someone an antipsychotic, I feel like I need to involve a trusted family member, whether this is lasting power of attorney or whether not, but someone in the family who has seen them through their journey of dementia. So once you involve them and once you speak to them and put it out in front of them, all those side effects, and then you document that, half of the times in my experience that they would come out with things which we can do to avoid that prescription. So I think that having the family on board is really important. And the other thing is that there are times when families say, yes, we are now at this point where this is the only thing which will help us now. And as a clinician, you feel comfortable as well prescribing something where, it's just not you imposing your expertise on someone. It is a joint decision. And I hope that everybody in Leeds does that to a good extent. So even if it's people in the care home, because it's easier to forget that, they're in, we go back and we speak to their families 100%.
Yeah. I totally agree with you. And when we did the toolkit, we put a big section in around shared decision making. I haven't put the 2 tools sometimes that I use, but you'll find them in toolkit about the number of excess deaths for people with stroke and or death from being on antipsychotic. And sometimes just just talking about those kind of numbers can really help people quantify that actually there's this many excess deaths if my relative goes on. And we always assume it's a bit like antibiotics, that because people come to us because they've got a distressed relative, that they want something, but sometimes just being heard about the distress and you acknowledging that actually that's really hard and they might need a bit of break from it actually, and then sharing with them, they don't automatically go for antipsychotics because actually they feel that actually there may be other alternatives. So I suggest, you're right, I suspect that's one of the key reasons that Leeds has done so well.
Just very quickly, another thing. We tend to hold back unless we see a psychotic symptom there, because 9 out of 10 times it's due to an environment or something else. So, you know, if there is something else which can be addressed, then you don't need to prescribe an antipsychotic. And to get that information is the key.
Yeah. I think you're right. Claire, do you want to come back in there, and then we can talk about maybe tools that people use to oh, actually, I'm going to say not Claire first. And Anna, you had your hand up first. Apologies for that, and then we'll come to you, Claire. Anna, what were your thoughts?
It's fine, and I'm a chief nursing officer for a care company with over 80 services over the UK, and I love the toolkit. I think it's going to be really useful. But what I'm finding in a majority of our services is, because of lack of funding in other areas, the first thing they think of is an antipsychotic, because we say we can't manage. Now, we have the tools, the training, but we have other residents and other staff to protect. And rather than look at this holistic approach, because of funding and because of lack of placements, specialist placements, the first thing they'll prescribe is antipsychotic, and it absolutely drives us insane when we scream out for support, and this is what we get. Whether it's just give them a subcutaneous injection of midazolam was what I was told the other day, and I said absolutely not. You know, we've got to look at the reasons for this, and this was a northeastern home, and we scream out for support and there's just none, and that's the frustration. We don't want antipsychotics. We know that people's falls increase, we know that behaviours change, and it is almost chemical restraint. It's awful to see. And you know, we don't want that, but we're left with very little option in care homes, and that is massive. And I'm trying to work with some areas, and I'm told funding, we don't have this, we don't have that. We can source so much, and we've done bespoke courses, but it is the first thing that is thought of, and that's really sad, really sad.
I think it is, and I think it's sad as well, because actually what they're not thinking of is the cost of falls and how many people go into hospital, fractured neck of femurs, episodes of delirium, and so I think people don't see the knock-on effects. So we've tried to put, where we can, business case material on why you might look at how you might get your place to think about alternatives. So letting them know how many falls are caused, actually what does this cost you to a system, because I think almost unless you sort of shake up the system a bit, it doesn't, you know. So actually using the toolkit, Anna, and sending it back to whoever is suggesting they don't have the resources, and asking it place, well, why don't we? Can we do this differently? I don't know. It'd be interesting to see how you get on, and whether actually asking that question helps.
It absolutely will be, and you know, it'll be the first thing I'll go to will be this toolkit, and it will be a really supportive mechanism, because it will give us some leverage to go, please don't do this, please help us manage this behaviour, with this being a last resort. And then through the pandemic, because visits were reduced and care homes had massive outbreaks, the first thing was an antipsychotic, because it was felt that was it. Now getting them to review is the other area, because I have a ridiculous amount of residents on antipsychotics, which I don't feel is massively appropriate. But I know I'm pushing from our end here, as I'm assuming other care providers are. It's just having that support is going to be huge in care, absolute huge. But thank you. It's a great tool. Yeah, thank you.
On reviews, and then I'll let Claire come in. We did hold a webinar last week for our pharmacy colleagues, and what I've said about deprescribing is that I don't think we can say it's any one person's job, because actually that one person needs the tool, but actually we need to do it together. So, you know, our pharmacy colleagues are up for deprescribing, but they need support of mental health colleagues and people who have experience, because actually there's a lot of trepidation, but they're absolutely willing. And one of the levers at the moment is that everybody has to have a structured medication review in a care home, at least annually. I know that's not every 6 weeks or anything like that, but that's an opportunity. And if they're not having that done, that's an opportunity to ask your practice pharmacist why it's not happening. Claire, did you want to come back in?
You're on mute, Claire.
Sorry.
All right.
Yeah, it was just to say that, you know, I'm a mental health practitioner coming from the occupational therapy background. And for me, working with people with dementia is really important for the non-pharmacological, for quality of life, and making sure they can engage in activities at their level of functioning and have routine and structure to the day. That is very important for everybody, not just people with dementia, but you know, people with dementia also need it, instead of being left in these distress states just to walk around and pace around, or, you know, them going out and wandering in the street, or not being very happy in self-care. You know, there's lots of things that I can help and provide, and I've just come from Leeds to Bradford to obviously do more of that, but I've been doing a lot of it in Leeds, behavioural care plans, expertise around that. You know, I've been up to my ears in it, and it's a good thing because it helps you to learn. And it is one of the things that I'm passionate about, is people being trained and developed in those ways, whether they're OTs or not, just to have that knowledge and to be able to bring that into, say, Anna's situation in the care home, where, you know, I don't believe there's enough mental health practitioners going into care homes, but at the same time, I don't think there's enough of us to do that as well. So to give the amount of resource that it would take. But I think they're going to have a strategy role in Bradford for dementia training, and that will be a good thing to get people trained to the dementia training standards, you know, that Health Education England have put in place. I think that needs to be implemented far and wide. Thanks very much.
Thank you, Claire. That's great. Anna, did you want to come back in, or is it a legacy?
Yeah, I think, you know, absolutely. I mean, as I say, training is often the best way forward, because if we can prevent behaviour, we then have less likely to use an antipsychotic or something to relax that person. And it is literally getting that training correct for that unit, that person, and everyone's different. So starting with that would be fantastic. And as I say, I'm in a really fortunate position that we tap into universities and everywhere, but sometimes we say, we've got this, what else have you got? And they go, nothing, there's an antipsychotic. And that's where that shift is a bit like, well, I don't want to do this, but this person is going to harm, or this person is putting others at risk. What do I do? And then sometimes we've got no choice, and we have to try it. And then we have falls, we have this, we have that, and then the person won't allow us to change their dressings. They become infected, they become septic, and it's harrowing. It's awful. But we've got to do something, and I think training is a massive part.
Yeah, and Anna, next week or the week after, we've got a similar webinar with community staff, so care home staff, GPs, and other community staff, which you might find other colleagues as well who can, you know, who might have similar experience, but also things to help. I don't know how many people are using. So I think in the toolkit you'll see that we've put resources around trying to understand behaviours and why they happen, like Clear and other resources. How much have people heard of those kind of things, and how much do you use those kind of resources to understand why distress is happening? Anybody who's not said anything so far? A bit shy today, aren't they?
Yeah.
Claire, were you going to speak there? Yes, I use the Clear. I understand Clear and Ian James Newcastle model, and those two do link in with Kitwood's work, Tom Kitwood, and the enhanced model of dementia care, which is written by a nurse, an OT, and a psychologist. and that's moving on Kitwood's work 12 years on. I think it's 2009, Dawn Brooker. But yes, I use them and I do find them very useful for help for, you know, for managing behaviour and improving communication between carers and the person with dementia. Also life story work as well.
Yeah.
It's a revelation, isn't it, when you hear of stories that have happened. I still remember one from the psychologist that works on the DAU at Hull, and this guy had been on multiple placements and been through multiple acute services, and they came to them and he was tearing radiators off walls and all sorts. Turned out he'd been a painter decorater, and actually once they worked out that that was part of the reasoning behind what was happening, they gave him water and a brush, and quite happily then, for a lot of the time, he was very happy. And actually what it meant was that we didn't understand, and we thought that the actions were deliberate and and aggressive, whereas actually they were him living in the world where he was still a decorator. So when you hear stories like that, it's a revelation that if you use the right tools and work out what's happening and know the person, how much difference it can make. Yeah. Alice, I can see that you've got your hands up. Please do come in.
Hiya. Sorry, I joined the meeting a bit late, so I hope this is relevant. I work in Rotherham, and I know that in the care home team, so I work in the memory service, but I know that in the care home team, they use the distress care pathway, looking at formulation, and also there's quite a lot of work with TPA Snow and ongoing training, sort of also with our staff in the memory service. So trying to sort of understand things better, and also, you know, do a lot of work around sort of sleep hygiene and things like that. And like you say, trying to work out and work with carers. We do the START program as well. So looking at sort of what are the triggers, you know, why is this person distressed? Like you say, are they in pain, or what's causing this, and what can we try and do to help, sort of, rather than obviously jumping straight in to looking at medication, because medication is just one sort of tiny part of things, isn't it? Need to sort of find out the root cause and see what we can do to help first. So I just wanted to say that, but like I say, I've come in a bit late. So
yeah, no, it's absolutely amazing. And Rotherham, I can't remember how good or bad their prescribing is of antipsychotics. Where on the naughty step you are compared to Bradford, which is on the really naughty step. Do you know where you are?
I'm not sure. I don't know if anyone else in the meeting will know.
So there's 7%.
Okay, so you're pretty low.
It's not bad.
No, it's not bad. So actually that sort of says, doesn't it, that if you've got that kind of services going on, actually you can reduce them. And that's why we should invest, isn't it? I mean, and we all know about the underinvestment in older age mental health services, but I think it's making that case. START program, again, that's included in the toolkit. Very interesting concept, and one of the researchers has presently moved to Catherine Lord to Bradford University. So we've got experts in region that know about the START program. Anybody else got a comment? Leela, you put something in the chat. Oh no, you didn't. It was Jessica said you hadn't heard of things.
No, I think it's the question, Sarah, about the percentage, because I'm the consultant for older people services in Rotherham. So yeah, I'm pleased to hear. It's obviously we lose track how much we're prescribing, isn't it? Like antipsychotics wise. And thanks to Alice kind of to chip in, because we both joined a bit late for this meeting. So I think it's again emphasizing the importance of non-pharmacological interventions, isn't it? And I think the difficulty is it's probably much easier to maybe think about non-pharmacological ones for the patients who are either in the inpatient setting or the care home setting. But when people are living in their own houses, that that can be quite challenging, especially in a crisis situation. Or, for example, if the patients are living by themselves, how can we support them? And we know that the social care is also struggling, as we are NHS. So, you know, yeah, those kind of patient group, I think I find it very challenging. And
What you'll find are two things that I think you'll find really useful in the toolkit is often you don't know as a place how good or bad you are. So I would really urge you to look at the toolkit and go and access your data, because what you don't know, you might think that you're really great or really terrible. And actually, when you look at the data, you may find the opposite is true, because you live in the same world that you've always lived in and you carry on doing the same old thing. So it's useful to have a look at your data and just see where you are. And so that's definitely worthwhile. The other thing, I was going to mention something else, but I can see Anna, have you got
Anna's still got a hand up.
Is that is a legacy?
Yes, it's an old one. I'll turn it off.
Oh, right, that's okay. Right. And I think you're right, Leela. The other thing is knowing who your population is. So we've had a bit of, we had all these thoughts in Bradford about, it's all because of X. And we thought, well, actually, you know, we know we've got quite a large population of people living in their own homes in multi-generational households. And we thought, well, that's got to be it. Well, actually, when we did some of the figures, actually still 400 out of the 700 prescriptions are in care homes. So actually, you'll find in the toolkit some really good audit tools to do at place to try and work out what your own individual nemesises are, where your problems lie. And so that can help you then decide, actually, where do we need to invest differently, or where do we need to work differently? But I agree, people living in their own home with families who aren't trained carers or by themselves is actually that can be quite a big challenge, and maybe needs a different approach, doesn't it? Is there anybody who's particularly used to supporting people in their own homes who have any? I can see that
we've got a hand up.
We have got a hand up. Kumar. Oh, hi, Kumar. How are you?
Oh, hi, Sarah. Yeah, good. Thank you. Nice to meet you here.
Yes.
I absolutely agree with you in terms of where I work in Norfolk, in a particular locality. We always assumed, you know, we do well and we don't prescribe, you know, in our crisis team. But even if we did prescribe, we only prescribe for a short period of time and ask our GP colleague to do the review. But when I looked at the data, we are also in a bit of on the what can I say? Nauticon. I think we are at the moment 12 point something, I think.
Okay.
If I'm right, you know, which is then, but again, it's not just our team, but again, as you know, we as a system we work with, you know, but again, when you see the data visually and also a bit of comparison, then you kind of know that, you know, you need to have a system approach, you know, because as you know that we in a provider, we don't just prescribe antipsychotic, you know, when the people are admitted into the hospital, you know, the acute hospital, it happens within the primary care. And as Anna mentioned earlier, you know, during a COVID time, it's peaked because of, as you know, that we couldn't see the patient. We just did telephone assessment, we prescribed it, you know. I think in the Norfolk, you know, we did a pilot, like a DIDEM tool approach in terms of diagnosing, you know. So in terms of, you know, we approached alternate way of doing a dementia diagnosis and including doing a review, you know, if they've been on antipsychotic, we did a review really. I think we assessed about 100 odd people, and among the 100 people, nearly 15 to 18 patients who were on antipsychotic, who had been actually prescribed for a long period. They hadn't had any review at all. And then we just literally were able to kind of do a review and discontinue those patients who's been on a medication for a while. I think often I can understand within the primary care, you know, they're hugely pressured in terms of, you know, not having a review. So you kind of almost, it does actually, you need to have a dedicated actual person to do the review, you know, and so that, you know, it can be reviewed and discontinued.
Totally agree. I mean, we looked in Bradford, and there's a lovely little tool within the toolkit that you can use to find out about attitudes and about how people feel about antipsychotics. So that was developed by one of the members of the toolkit steering committee as part of her fellowship, and it asked the question about how people felt about deprescribing, how they felt about antipsychotics. So, and one of the things that she found was that people are really worried about deprescribing as if something really absolutely terrible was going to happen. They didn't know how to do it, they were really worried about doing it. Were they going to take this kind of lid off the kind of worms, and was it all going to go terrible? And the answer was, actually, if you did it slowly and you did it at the right pace with the care home and with the relatives, actually you could do that. And it isn't a race to the bottom, it's taking people along with you. And we're happy to deprescribe other things, but antipsychotics lead us into great fear. And it's often that stopped people stopping them when they, Kumar, when the GPs did the reviews, they just didn't really feel capable of doing it, which I think is quite, well, it's a salient lesson for us all, isn't it? We can say just stop things, but actually it's not always as easy as that.
No, it's not. It often what we found is fear, in terms of, a placement may break down. So that means there is no alternate placement. But as you know, that when our crisis team, they go and do an assessment, we actually agree for admission, but there isn't a bed. There are people after waiting for a bed. What do we do in the meanwhile? But I totally agree. The care home are not asking for antipsychotic, so they're asking for a help and a support. I think often, if we can just, even though we have to prescribe it, sometimes we do, but again, it's about, how do we prescribe and do a review and at least prescribe when needed.
I totally agree, and that goes back to Anna's point. Homes aren't asking for an antipsychotic; they're asking for help and support.
Yes, yeah.
Are there any other people that would like to comment, question, share a thought?
A question in the chat box about where to access antipsychotics data. So I've put a link in there to so there's a monthly publication basically from NHS Digital that it has the monthly dementia diagnosis rates, and it has the antipsychotic rates in there as well. As a clinical network, we do a bit of a dashboard, a monthly dashboard, and I'll put the link into that in the chat box as well, because that kind of it breaks it down just for the Yorkshire and Humber region. I know that this is a wider geography than just Yorkshire and Humber, but the Yorkshire and Humber might be helpful, so I'll pop a link in to that as well.
Absolutely, and I think that toolkit is that published on NHS Futures as well, monthly as well, Colin?
I'm not sure about that, Sarah. I'll look into that. If it is, I'll send a link round to that as well.
The other thing is that's published monthly, but on the OHID, which is the old public health bit of the website of at NHS England, you can see they do about roughly quarterly returns about your place, and what you can see then is the higher prescribing practices, and you can see so the last data is July, but so it'll tell you a bit more about your place, how many dementia reviews are going on, what your dementia diagnosis rate is, and the higher prescribing practices. And when you look at them, you'll probably say, oh, well, actually they have large care homes or whatever it is, but they'll show you the ones that are out of sync really, and again gives you some avenues of how you can target your support within your place. So that goes down to practice level from the old CCG partnership, what are now health and care partnerships. But I love data because I think data allows you to just see and benchmark yourself. And what we're obviously hoping is that 9 point whatever gradually starts to come down. And so, but really need to look at where you are in that data stream. Okay. So have we got any more hands up? No. Okay. And have we answered all the questions that are in the chat box?
I think so, Sarah. Yeah, I don't think there's anything we haven't covered.
Yeah. Jessica, you put a comment a little while back and you put, I haven't heard of them. Were you talking around some of the tools to help understand distress behaviours? I can see you from a GP practice. Okay. Jessica might not.
Oh yes,
Yeah. Okay.
I'm taking surgery.
Okay. All right. Okay. All right. Don't worry. So I must say, as a from a GP in practice before, obviously it's different. I always feel that I'm in the know because I, wonderful colleagues who tell me about all these things. I learn all about things like Clear, but I do think there's probably a lack of training within primary care on how do we support distress, and actually, and so we've not probably understood that distress is due to pain, hunger, anger, thirst, and boredom. So we probably haven't understood why behaviours happen and just see them as part of inevitability of dementia, whereas that is obviously not true. So I do think from a primary care point of view, we probably need to develop better understandings of why behaviours happen and how to understand how that distress has come about. And that's why stuff like Clear, but it's probably one of those things you have to do as a system, don't you? You can't just suddenly go in as a GP and go, have you just seen this? But you can, some of these things are relatively easy to use. But yeah, definitely using them as a system. There is a Clear section on the NHS Futures, isn't there? A sort of a Clear platform, isn't there, Colin? A group of places using Clear tool.
I think so. Yeah. I'll try and find out the link to that, so we can share that with everybody who's been on today. Yeah.
Okay. Anybody else want to say anything, or are we actually going to allow you to have a bit of an early lunch if you haven't? Yes, 10 minutes of a breather before your next thing. I'm just going to check I've answered all the questions in the chat box. But please do feedback on the toolkit. We hope you find it useful. And if you do manage to bring down your antipsychotic prescribing rates, we'd love to hear from people and what kind of things they've found that have been most successful to do that. We'll be able to see that because we're always voyeuring into the rates every month, so we can see when places are having big changes. And just one thing, just to bring, maybe just to mention from where we're at in Bradford, what we found was actually, 15% was 700 and something people living with dementia. And what we found is if we change how we start new people, all right, so we say from today we will always do, and we're in the middle of producing this now, thinking about shared decision making, shared risk taking with families, documenting why, what symptoms we're hoping to do, what the review. We're hoping that if we start that now, then actually that doesn't change the people who are already on it, but we can stop more people joining that cohort of people that we're going to de-prescribe, because we're starting with new thoughts for every new prescription. And I think small things like that can change a really big task into a manageable chunk. So it would be really useful if other areas have strategies that have worked, then would love to hear from them. So if there are no more questions, thank you all very much for joining. It looks like Rotherham were out in force looking at the chat box. Lovely to hear from you, and I hope people found it useful. But and if you think of stuff afterwards and you're a bit too shy to say anything, please do email us, and we'll see if we can send you the answers or signpost you in the right direction. So thank you very much, everybody. Have a lovely lunchtime.
Thank you, everyone. And we will send the slides around from today and the recording to the meeting.
Thank you.
Thank you, everyone.
Thank you very much.
Thank you.
Bye bye now.